number 9, the Shepard Explorer. Okay, so procedure: wears all PPEs, positions the operator and patient properly, maintains proper visibility by the use of the dental light and dental mirror, uses sequence of tooth numbers 1 to 16 and then 17 to 32. So if you don't know your teeth numbers, now is going to be the time to start learning them. Uses appropriate. Yes, ma'am.
Ms. Reed,
yes, ma'am.
tell them the purpose of this instrument.
So this is an Explorer. You'll be using this Explorer to explore for decay, to check around restorations. That's mostly what we're using this for. So you'll be using this when you're doing hard tissue charting.
This one we stick the gum?
No. Do not stick the gums with this one.
Yep,
Your patient will leave the clinic.
Just hard tissue or enamel.
Yeah.
Okay.
Uses an appropriate grasp. So what grasp is that? Modified pen grasp. Establishes an appropriate fulcrum as close to the working area as possible.
So for the maxillary arch, it probably says that, but
where did it say it? At the bottom, it does say maxillary at the rear and mandibular as at the front.
okay. So
My CE may be an older one. I'm not sure. No, I think it's the same one.
I think it's the same. Okay. So for the Explorer, the Shepherd's hook on the maxillary teeth, you'll be in the rear of the patient. Now, the rear actually just describes the area between 10 o'clock and 12 o'clock around the patient's head. So if you're right-handed, 10 o'clock to 12 o'clock would be from the tip of the patient's ear around to the back of the head, okay? If you're a left-handed clinician, it would be from 2 o'clock to 12 o'clock and sometimes even 11 o'clock, depending, for lefties. But that would be the same position from the tip of the patient's ear around to the rear or the back of the head. So when we say rear, sometimes it's a misconception that we mean directly behind the patient's head. The rear can be anywhere from those areas, okay? Because sometimes it's difficult to see everything directly from behind the patient. Also remembering too that sometimes it's necessary to have the patient turn their head, okay? So remember your positioning, CE. That includes having the patient turn to the left or the right, in addition to having them tilt their chin down or tilt their chin up, depending on maxillary and mandibular, all right? So that's good there. For the exploration of the molar teeth on the upper right, for right-handed clinicians, you will need to fulcrum on either the buccal surface, buccal meaning the surface closest to the cheek, right? So the buccal surface of the tooth here, and what you're going to use is a rocking motion with your fulcrum to create what we call a push-pull stroke. And so what you'll see inside of the mouth as I'm exploring is the Explorer goes in and out of the enamel surface. And like Ms. Reed mentioned, what you're checking for, number 1, is any sticky areas. So sticky areas would mean that there's decay or softening of the tooth enamel, which is not good, right? So you're checking for sticky areas or soft areas on the enamel to indicate decay. Legally, as hygienists, we don't diagnose decay. What we do is we call it a suspicious area, okay? A suspicious area is our way legally of saying there's decay there, okay? We know what decay looks like and feels like, but legally we cannot diagnose it for the patient, all right? Or you might find an area where there is a really deep groove or pit on the occlusal surface of the tooth. And so sometimes your Explorer will catch there as well, but it's not sticky, it's just catching. That would be what we would call a watch area, meaning it's kind of deep, right? But there's no indication of decay there. but there is an area there that we want to monitor or watch over the course of the patient's treatments to make sure that it does not turn into a problem or turn into a decayed area, okay? So when you are doing dental charting, which we'll go over later, you will be charting these areas as you explore them, okay? So we're checking all the molars, but if we imagine there was a cheek here, right? You wouldn't be able to stick your finger all the way back here on the first molar, number 1, right? So you would actually have to fulcrum in front of the tooth and explore backward, okay? It's a lot easier than it sounds, all right? So what I'm doing is I'm fulcruming on tooth number 3, and I'm extending my instrument back to actually explore tooth number 1, okay? And as you come forward, you're checking premolars. You're also checking around the margin of a patient's restorations. So restorations have an outlying margin or demarcation where you can actually detect if there is what we call recurrent decay. So a restoration is actually something that's placed on a tooth to treat decay, right? But sometimes a patient can get additional decay underneath the restoration. So you're checking to make sure that the restoration is indeed intact, as well as whether or not there is recurrent decay around the restoration as well. So you're just going to use the tip of your explorer to check for any soft, sticky areas or any catching areas with your explorer. In the anterior, you also may find restorations. You can use your explorer on the anterior. However, in most cases, with a tooth that's intact with no restorations, you won't really need the explorer in the anterior. Another area in the anterior that you might need your explorer for is on the lingual surface. Do you remember the cusp that can be found on the lingual surface of the canine and the lateral incisor, right? So you may want to check those because some patients have a more prominent cusp on the lingual of those teeth. Sometimes on the lingual of the canine or the lateral incisor, they call it a talon cusp. It's a very deep depression or groove on the lingual surface of the tooth. So what would you be checking that area for? What do you think? Decay, right? So sticky areas. The sticky area will feel like you're sticking the tip of the instrument into the top of an eraser, right? So if you have a pencil and you can stick it in the top of an eraser, you can feel how it just kind of sticks, and then as you pull it out, it hesitates to come out. That's how decay typically will feel. Now, if you see an obvious area of decay, meaning a big black hole in the tooth, you do not have to stick this instrument into that area to know it's decay, okay? This would be more so for smaller areas of decay or what we call incipient caries, or areas where it might look like stain. You're not sure if it's stain or if it's actually decay. You can check it, and then of course checking the restorations. As you come around, and especially on the lingual, you're going to need the mirror to see. As you come around, you just bring your fulcrum with you, okay? Because you always want a fulcrum close to the tooth surface that you're working on, yes? And then, of course, you might also turn the patient's head. So we're still in righty position here. So if I'm on the right side of the patient and I need to see surfaces farther away from me, then I'll have the patient turn towards me. Does that make sense? To bring those surfaces closer to my view. So I'm using this mirror here to retract. Sometimes I can use the mirror to retract and to see, using a separated grasp on the outside of the patient's mouth, right? Like we learned with our mouth mirror. And I'm doing a push-pull stroke on the occlusal surfaces of the teeth. Now, in addition to the occlusal surfaces, sometimes patients have deeper grooves on the buccal here, the buccal groove or the lingual groove. You want to check those as well. How do you do that? You simply pivot your hand to the facial or buccal, or pivot your hand to the lingual. You see how I did that? So my fulcrum is still in place. Push-pull takes me in a rocking motion. The pivot takes me from one side to the other side without having to move the fulcrum, okay? You might also have restorations on the buccal or lingual surfaces of the molar teeth. You'll want to check those as well, okay? On the mandibular, I'm actually going to be in front of the patient here. So it's a lot easier for me to do my push-pull in front of the patient on the mandibular, and as well as see the teeth and also retract the tongue, right? So I'm doing a push-pull. That's my rocking motion. If I need to check the buccal or lingual surfaces, I'm going to do what again? Pivot, right, left. So rocking goes in and out, push-pull on the occlusal surface, and then you pivot and then push-pull on the buccal, on the lingual, right? Now come around. The surface closest to me would be the right side. So I would fulcrum maybe 1 to 3 teeth away from the tooth that I'm working on. Checking the occlusals, lingual, and buccal surface. In addition to pivoting, it might also be necessary to roll the instrument in your fingers. So if I pivot this way, my tip of my instrument is actually pointing down to the floor of the mouth. But if I roll the instrument, now it's pointing toward the lingual surface. Again, if I pivot my fulcrum hand or my fulcrum finger here, I need to also roll the instrument so that the tip actually is inserted or facing the surface that I need to explore. So I can do that again a little closer if you'd like. But that's you incorporating everything that you've learned from your grasp and fulcrum, right? So the rock, the pivot, and the roll of the instrument. And that's it. That's me checking all of those surfaces. You'll notice that I don't focus on the interior quite as much. The main purpose of exploring interior teeth would be if there were extra grooves or pits of those teeth or restorations on those teeth. Otherwise, you really don't want to take this instrument tip onto the surface of intact enamel just for the fun of it, okay? It's an explorer, so you're checking the teeth, okay? So if there's nothing to check, then you can move on, okay? Questions? Well, actually, we need to make sure we covered everything on the CE too.
So, drying the teeth with compressed air for better visibility. Drying the teeth helps. Sometimes those saliva bubbles will cover, especially composites. So that helps those to really stand out. So make sure you use your air with your air water syringe.
Or ask the patient if they're sensitive to air. If they are, you can dry the teeth with the gauze.
Gauze, yes. Adapts the point of the explorer into the pits and fissures at the correct angle using all those adaptations like Miss Martin showed you. Verbalizes the correct use of the Shepard's hook explorer and verbalizes the indication of caries. Charts caries and watch areas on the dental charting form using correct EagleSoft symbols. Evaluates the margins of all restorations for recurrent decay. Stop me if you
Yeah,
want to say
so
something.
actually, let's add that to that, I should say. We talked about the restorations having an outlying margin that you're going to check. Another common area where you will see restorations potentially would be at the cervical third of the tooth. You may also see a restoration on the cervical third of anterior teeth as well. Is everyone familiar with what surface the cervical third is? So right around the gingival margin, okay? So for patients in some cases who've had gingival recession or root decay, there may be a restoration right along the gingival margin area. So when you are exploring the tooth, you would pivot and roll the instrument tip to check around the margin, not to place the tip subgingivally, but actually to just check around the restoration margin at the gingival margin, okay? So be careful with that. Make sure your fulcrum is stable, because what you don't want is to poke the tissue, right? You're literally just checking the margin of the restoration for how intact it is and if there is any recurrent decay. Okay.
One more tooth over here so I can get a better.
So I would check the margin of, and this is a tooth without an actual restoration, but this is
So that's
how it would
really
look.
helpful when patients have crowns. You still have to go around, you know, the crown goes all the way down to the gums and sometimes under, but you still have to check the margin of a crown.
That is correct.
Okay, thank you. Let's see. So it maintains correct patient-operator positioning. Patient's mouth is adjacent to your elbow. Clinician's body is in neutral position. Verbalizes all procedures, uses standard precautions and PPE, and documents in progress notes. So, like we said, a potential carious lesion feels like inserting and removing the Shepard's hook into a pencil eraser. And you're using a push-pull stroke. And in the past, we've talked about it's not a scratch; it's the push and pull.
Also, to that point, since it's not a scratch, you're actually using your fulcrum and your whole hand with the movement. So no independent finger movement unless you have to pivot and come to a certain area here, like on the lingual or the buccal. You might have to use a little independent finger motion there. That's fine. But in most cases, especially on the occlusal surface, it's an entire hand movement stabilized by the fulcrum finger. In addition to that, I think Dr. Barnes, you made a point too about the Shepard's hook, and I'm drawing a blank.
I can't remember what we talked about.
Oh boy,
What's it in reference to?
what did you just say last? Pressure. Too much pressure. So, you don't want to use too much force when you're doing this. So sometimes we've seen students and they're stabbing the teeth, right? So the purpose is not to, disturb the enamel matrix of the tooth or cause sensitivity. You actually are just checking the pits and grooves. So it doesn't take a lot of force, okay? So don't use too much pressure. And it's easy to do that with a typhonaut because it's not a real person. But just be mindful that it's just a gentle push-pull stroke. And you're trying to see if there is any catching of the instrument on the tooth surface, okay? So just be mindful of the pressure that you're using as well. But that is it, I do believe.
Okay.
Yep. Questions?
I have one.
Yes.
So when I went to the dentist, but I think she used the Shepard's hook when she was on in my mouth, and she was saying she was calling out to her assistant like OB and what does that mean?
So not for this CE, but for maybe the next it's like number 5 after this. Dental charting. So you will be responsible for recording existing restorations in the patient's mouth. So for example, for you, there was your dentist might have been calling out work that needed to be done or work that you had already had done. But when you are exploring, you're not only checking for restorations and decay, you're also going to be recording or charting existing restorations. And so we'll get into all of that with the dental charting CE. Okay. It's a little bit more involved, right? But those items that your dentist was calling out were 2 surfaces. So you have mesial, occlusal, distal, lingual. And so if there's a restoration